Hi, everybody. Welcome to the 71st American Healthcare Association and National Center for Assisted Living Convention and Expo, and the first virtual convention and expo. Our topic for today's presentation is Enhanced Enforcement Penalties for Infection Control Citations. This presentation is being done jointly by Team TSI and Regs in a Flash. My name is Greg Seipel. I'm the Vice President of Clinical Informatics for Team TSI, and I will be joined today by two other colleagues that will be helping us through this presentation. Pat Newberry, the Vice President of Clinical Services here at Team TSI. Pat has a lot of experience in both as a physical therapist as well as clinical reimbursement and expert level knowledge of the MDS. Hugh Heaton, you may recall his name from the Heaton manuals. He is the CEO of Regs in a Flash. Extensive experience in skilled nursing and long-term care, in writing policies and procedures, and knowledge base for regulatory process is unsurpassed. So thank you both for joining us for this presentation, and we look forward to providing the information to all of the attendees. The learning objectives for this presentation: upon completion, we should be able to specifically identify the two factors that drive penalties that will be assessed for infection control citations. We know with the advent of COVID-19 and the public health emergency and the national pandemic, the focus on infection control surveys and citations has never been greater. There does not appear to be any indication that this is going to lessen or go away. In fact, it appears the scrutiny will only become more severe, hence the enhanced enforcement remedies. We're going to also be able to describe the criteria and the penalties that result from infection control noncompliance at different scope and severity levels. Additionally, we'll be able to discuss the COVID-19 survey activities that CMS will be conducting. For the background into this, I'm actually going to turn this over to Pat Newberry at this point in time. Pat, please take it away.
Thank you, Greg. And just to talk a little bit about the background and what's led us to this is, as we know, we've talked about that this COVID pandemic is raging on. There's no sign that it's going to be letting up anytime soon. Our long-term care residents are at enhanced risk of infection and an exposure to COVID. So that CMS has really kind of put the nursing home facility practices back under the microscope. So with that, we are looking at the renewed QSO letter that was issued in June of 2020, talking about the enhanced enforcement penalties that facilities are now going to be facing, really related to this F880 infection prevention and control requirements. This is they're going to be imposing remedies for deficiencies associated with a D level and higher scope and severity, and I think that's really very, very new to us. We know that we write plan of corrections for the D level, but associating some of the enhanced enforcement that you're going to be seeing here in a few minutes, I think really needs to be brought into consideration. It's going to be actually, the remedy is going to be based on two very specific factors. The first one is not just your current compliance history, but your past compliance. You know, we've never really looked at the D levels in the past history before, but they become extremely important as we look to what's going on with infection control. So it's your past and current compliance history, and also the scope and severity of the particular citation. So you're going to see different things from a D and an E level to an F, and your G, H, and I, and immediate jeopardies. So let's talk first about what happens if you have no deficiencies in the last year or your last standard survey. What are the things that you need to be looking at? If your citation that you're on your current survey is a D or an E level, you're going to be looking at a directed plan of correction. All of us pretty much know what those are, including the use of a root cause analysis. He's going to be talking in depth about this a little bit later on in this presentation. So if you are cited at an F level, you'll have that directed plan of correction, and in addition to that, there is a discretionary DPNA or denial of payment on new admissions that CMS can impose. With all of this, the facility is going to have 45 days to demonstrate the compliance with these infection control deficiencies. Now we're going to take it on to what happens if you've had one infection control deficiency in the last year or on your last standard survey. We know some of you all have gone way more than a year. So looking at your last standard, if you're cited at a D or an E level, then what you're going to be seeing with this is your directed plan of correction and that discretionary DPNA that can be attached to it. But in addition to that, there is going to be a CMP or civil money penalty at $5,000 per instance. So that's kind of new for a D or an E level, and that's important for you to acknowledge or recognize. And again, the facility is going to have 45 days to demonstrate the compliance with these deficiencies. Now let's take it on to what happens if your scope and severity is an F level citation. Again, you'll have a directed plan of correction. You'll have a discretionary DPNA. And now in addition to that, you'll have a $10,000 per instance civil money penalty. And again, 45 days to demonstrate your compliance. Now what happens if in the past 2 years, you've had 2 or more infection control deficiencies? Now the things take on an even more intense remedy. So let's look at that D&E level. At a D&E, if you've had 2 or more citations in the past 2 years, you're going to have your directed plan of correction. You're going to have that discretionary DPNA. But now there's a little bit of a twist. You're going to have either a $15,000 per instance CMP, or you could have a per day CMP. If they're going to cite a per day CMP, then it has to be greater than 15,000. So if you've had 2 or more citations in the past 2 years, a D or an E, a minimum that you'll be cited for your civil money penalty will be $15,000. Now, what happens if it's an F level? Basically, if it's an F level, things go up a little higher. So you're going to have, again, your directed plan of correction, your discretionary DPNA. Now you're going to have a $20,000 per instance CMP, again, or you could have a per day as long as it's greater than, the cumulative amount is greater than $20,000. Now here's a little bit of a difference. Now you're going to have, just like with your D&E level, you're going to have 30 days to demonstrate compliance. So when you have 2 or more citations in the past 2 years, your civil money penalties increase, and you only have 30 days to demonstrate compliance versus 45 days if you don't have a history or if you only have 1 citation. Now, as we get ready to go into the G through L level, I'm going to turn this over to Hugh, and he's going to talk about the G levels all the way through the immediate jeopardies and the consequences of those. So, Hugh?
Thank you, Pat. Thank you, Greg. It is a pleasure to present along with you. I hope that what we are going to look at will provide some insight into how the enforcement remedies work. What Pat has reviewed are what happens if I have 1, 2, or more deficiencies. But now the penalties change. In the infection control with a G and L, the deficiencies are regardless of what your past history, and that's critical. Each one of the infection control remedies is a directed plan of correction, which includes the use of a root cause analysis. And looking at the root cause analysis, what the survey team or the CMS or your state agency is going to look at when you submit your plan of correction, which you will have to do. Even though it's a directed plan of correction, you have to submit a plan of correction, which includes your root cause analysis based on the information that I have received from some of the state agency that I have talked with. What they're looking for is you can include in the plan of correction what the root cause analysis revealed and the corrective measures. You do not have to submit your entire root cause analysis, and we will look at some of that in just a second. but if they need additional information, they will ask for that. What they are looking at is on the revisit for the root cause analysis is for the QA plan. The root cause analysis must be a part of your QA plan. And when the survey team does a revisit, they're going to ask for that documentation. And the purpose of that is to determine what your earliest compliance date was. If there's no evidence in the QA plan of their participation in that, the earliest date of compliance will be the date of revisit. So that's important to look at that, to be sure that your QA plan addresses this. Another key factor that you would want to be sure as a part of the root cause analysis and the QA plan is what role your infection preventionist plays in that. As you've seen in the current regulations that were released recently, Tag 886 requires some of that, or some of the newest information requires the infectionist preventionist to be a part of the QA plan or your cooperative committee. So they will look at that. The way that they're going to ask you to submit that information is through your EPOC. And if you do not have an EPOC plan, you can access your CASPER. I believe that there's a way to apply for the EPOC where they place that information in there. Greg's going to be talking about Tag 884 as it relates to some of this, and the way that they provide that information on the Tag 884, which deals with the COVID reporting that you do every week. They place that information into an EPOC file. So you may want to be checking to be sure that you are looking at your EPOC file continually, because that's where that information is going to be placed. It also, in addition, as Pat has discussed, it also requires a discretionary DPNA. There are two DPNAs. There's a discretionary DPNA, and there's a denial of payment for all admissions. But this one deals with just the denial of payment for new admissions. The CMPs are going to be different here. What you're going to look at is, the CMS will determine what the CMP will be. It will be based on within the range of non-immediate jeopardy, as it is outlined in the CMP analytic tool. If you go on to the CMS website, you can locate S&C letter 17-37 that was released in July of 2017. That particular letter has the analytic tool that CMS uses and how they're going to assign penalties. It's a really easy document to look at, but it provides all of the CMP ranges. And again, that's S&C letter 17-37. If you don't find that, you have a slide that has our contact information. If you will contact me, I will send you that letter as well. But in addition to the CMPs and to the discretionary DPNA, this one allows you, they will also add additional enforcement. They don't have to stay within just those two remedies. They can add additional remedies. And like the two or more deficiencies, you have 30 days to demonstrate compliance. Based on what I've read and studied in that 30 days, that will be 30 days from the date that you receive notice of the imposed penalties. So as the deficiency levels get higher, so do the penalties. For example, you will see on the JK&L totally different. They added mandatory termination or imposition of a temporary manager. When that's imposed, that's an automatic loss of your nurse aid training program. So is a $10,000 penalty. So those are serious. It also, again, it has the directed plan of correction, including the root cause analysis. Each one of the directed plan of correction requires a root cause analysis. And I want to remind us that these enforcement remedies currently only apply for tag F880. Doesn't apply to any other infection control tag, just F880. It also has a discretionary DPNA, and it also has the enforcement is imposed by CMS, and just like the GHNI, it's within the CMP range of immediate jeopardy, and that analytic tool provides you with information. The other factor that's key here is you only have 15 days to demonstrate compliance. So a JKRL is very serious, and this is the G through L is regardless of your past compliance history. So that's a review of the penalties based on scope and severity. But one of the things that we wanted to show you in your handouts, you have this session has a tremendous number of handouts with it. It has all the S&C letters that we talked about other than 17-17. It doesn't have that one. But it does have all of the current letters based on the enforcement process. It has your guidelines for a directed plan of correction. Those state operation guides are there as well. But it also has a root cause analysis, and we only just want to go through just a couple of pages of it, just how detailed it is. This is only for tag 880. The first process that it looks at is the citation history, and Pat mentioned that. It's very important that we look at our past compliance history, especially if you look at number 4 on the screen. You see if the facility has been cited and received a citation in which you had an IDR or an independent IDR. I would encourage you to look at that. If you have had an IDR or an independent IDR on tag 880 in the past, look at that. What was the result of it? And if you were successful and you did not request a new plan of correction and submit a new plan of correction, then the original deficiency is what's posted on Nursing Home Compare. So what that's saying in the IDR rules is if you do not request a new plan of correction and sign it and submit it, then your original deficiency is posted. Sometimes we look on Nursing Home Compare and we'll say, well, that deficiency shouldn't be there. You may want to look and determine. So it's very critical that you look at that, especially with these new enhanced enforcement requirements. So the first page just goes through your past compliance history in order to help you work through this root cause analysis. In your handouts, it is handout number 7. It is a digital file, so you'll be able to complete this on your computer. It's a PDF. It's digital. You can print the document. You can save as, or if you want to reset the form, you can do that. The next page we want to show you. Now, this is a 9-page form, but I just wanted to show you this particular page. This is the worksheet when you're doing a root cause analysis for tag 880. there in the root cause analysis guidelines, it talks about looking at the components of the regulation. And if you noticed, there are 13 different components of tag 880. And we have to look at each one of those to determine which one of these could have been the root cause. And so this gives you an opportunity to just check the box. Do I want to investigate further? Which one of these 13? Do I need to look at all of them? Can I find that maybe it was just I didn't have a policy for that particular cause? But this allows you to do that. The remaining portion of the root cause analysis form that you have is just a document that allows you to identify the problem. Was it isolated? Is it pattern? Is it widespread? Where does it happen? All the way through the root cause analysis process of elimination. And it's all of the questions are asked. It all deals only with your infection control. It's a 3-page document for the root cause analysis. And then the last page of your analysis is a follow-up worksheet. Did my root cause work? Because what's taking place in the survey process with the root cause analysis and with follow-up, what the state agencies are looking for on your plan of correction was that if I did a training program or the corrective action that I implemented, was it successful in removing the root cause? And what measures did I implement to determine that? I can't just put on the plan of correction. We had an in-service training and we're all trained on that. What they want to know is, did you have a pretest, for example? How did you measure the success? I did a pretest and a post-test. I did an interview. So they're looking for that information. So I know that's a lot of information to look at, but I think you'll find your root cause analysis program very easy to use. And with that, I'm going to turn it back to Greg as he's going to look at some of the 884 and 885 requirements.
Thank you so much, sir. So part of the focus for this presentation as well was to look at 2 of the new federal F-tags that were introduced into the Code of Federal Regulations in response to COVID-19, public health emergency, the national pandemic, and that's F884 and F885. These were introduced through QSO letters, specifically F884, QSO letter 2029, which directly relates to the nursing home's responsibility to report COVID-19 facility data to the CDC on residents, representatives, and families on a weekly basis. The information has to be submitted minimum of every 7 days. You can submit more frequently than that, but your minimum requirement is every 7 days. And then, of course, we know that data is being publicly released through Nursing Home Compare with about 11-day lag between that information showing. The compliance for F884 is conducted off-site by CMS. They look at the weekly data report to CDC. If you have failed to submit the data, or if you failed the quality check, you are at risk of receiving penalties or enhanced enforcement remedies in response to this criteria. That's going to take the form of civil money penalties as well as F-level citations for this particular tag. Now remember, keep in mind, this is not something that's going to be reviewed during a state agency coming on site to review. This is a CMS imposition. If you're not reporting the information weekly, you're automatically going to get an F-level citation, and you'll get a 1-day CMP of $1,000. Right now, how these tags are being aggregated in response to your 5-star rating and your survey scores is somewhat unclear. We're not entirely sure where it's going to aggregate up in and have an impact on your rating reports. But bear in mind that an F-level citation is a minimum of 16 points. That could potentially be tallied against you for your 5-star rating for the survey. So if you neglect or fail the quality check or in some way, shape, or form are not able to submit the information for that week to the CDC, you're going to receive a $1,000 citation, or forgive me, a $1,000 CMP and an F-level citation for FTAG 884. Each week that you continue to fail to submit, the CMP amount is increased by $500 for each week the data is not submitted. That does not reset if you submit for 3 weeks in a row and then fail to submit for another week. The $500 addition keeps aggregating for each week that hasn't been submitted. So you do not get a reprieve, you do not get a break from the civil money penalties if you skip a week. It's still going to be applied, it's still going to be relevant for your facility, the FTAG is still going to be cited. For F885, this FTAG was specific to reporting COVID-19 information to residents. This is conducted on site during a COVID-19 focused survey process. It'll most likely be part of the infection control survey process moving forward. We know moving into 2021, 20% of all nursing homes will have a focused infection control survey process. They will measure whether or not you are compliant with the notification requirements for F885 while they are on site. Surveyors are going to ask for proof of the notifications to residents, representatives, and families. And we know there's multiple ways that notification can take place. It can be done through a web page. There was never a requirement that you had to individually call or notify each representative or family or resident one-on-one, but you had to make a good faith effort in order to ensure that the information was being shared. Updates were done at a minimum of a weekly basis. Remember, part of this requirement as well is to ensure that that notification occurs by 5 p.m. the next day when you've met the criteria of either a new positive case or 3 or more respiratory cases that are suspected or confirmed within a 72-hour period. So that notification requirement, if you are found to be in noncompliance, when you get a citation on the 2567, they'll do the enforcement action in accordance with the QSO letter 2020, and you will be subject to whatever standard enforcement remedies apply for that particular. Again, we have 2 new tags that we're contending with, F884, F885. They're not going to be going away anytime soon. This is sort of the world we're living in at this point in time. As again, information being released to Nursing Home Compare means that there's that transparency they're trying to establish as well that allows anybody, any consumer, any family member, any resident, activist group, anybody to go in and validate that the information is being provided on F884. And then, of course, they'll come in and see if you've been compliant. Remember, they can look at your information in your weekly release to know if you've had one of these particular incidents, if you've met a criteria that requires notification, and they can certainly request evidence of that notification, proof of that notification being done to determine if they'll cite this level as well. The survey activities involved in this, we're now requiring state agencies to implement the following COVID-19 survey activities. This is all, again, part of the QSO letter as well, that if you, within 3 to 5 days of identification of 3 or more new COVID-19 confirmed cases, since the last time data was submitted to the NHSN, the expectation is within 3 to 5 days of that event occurring, there will be an on-site survey. Surveyors will come in, evaluate your infection control practices, ensure you're compliant with the regulatory requirements, because, again, they're trying to avoid outbreaks or hotspots from developing. Addition to that is that if you have 1 confirmed resident case in a facility that was previously COVID-free, not COVID-free for a period of time, but you're essentially reporting your very first confirmed COVID case in your center for the year. You've not had to deal with it before. That's going to prompt also within 3 to 5 days an on-site survey. And the focus there, of course, being if you've not really dealt with it to the level that some of the facilities have, who've been dealing with either specialty units or taking admissions or had outbreaks in their facility, they definitely want to avoid the possibility of an outbreak. So they are absolutely going to come in and do infection control surveillance monitoring for you, a focused infection to ensure that you are meeting the required standards for infection control at F880. And of course, if you're not, citations will ensue for that. This is one that probably gets the greater focus of the 2 3 or more new cases may be respondent to a facility that does have a COVID unit. Surveyors may have already been out. Again, it'll depend on the state agency and how the enforcement action is applied, but it may not get quite the level of scrutiny that a brand new confirmed first-time case is going to get. They definitely want to ensure that they're avoiding the negative outcome of a possible outbreak. And remember that starting in October, annual focus control survey of 20% of nursing homes, and I may have misspoke when I said 2021, based on state discretion or additional information that identifies facility and community risks. Remember, some of the information is being reported while it may not be part of the NHSN weekly questionnaire. What is extrapolated are community rates. Looking at that information as well to determine in your county, what your infection rate is in your county is certainly going to be indicative in your reopening plans, how you're going to begin taking new admissions. If you're a hot spot, you may have to really judiciously determine when you're going to move from phase 1 to phase 2 versus phase 3 and resume somewhat normal activities. If anything can be considered normal in this day and age with the pandemic. So there's a number of ways people can sort of look at that aggregate data. The file that is released on a weekly basis, again, it's 11 days old generally from the data that had been submitted. That's to allow for quality check. But compiling that data and looking where your risks may lie, there's a number of ways you can do that. There are some organizations out there that have basically taken the data file and compiled it into a viewable format to allow facilities, organizations, either at a corporate, a division, a regional level, down to the facility level to determine where risks may in fact lie. This is one such report that is going to basically take the CMS data release. It'll give you the date of the data release as well as the week ending period and sort of compile that information up at a corporate level that is then drillable down to other levels as well. At the facility level, it would show not just the facilities rates. Again, the cases per 1,000 residents is extrapolated from the CMS data, which show both the facility rate, the county rate, the state rate, and the national rate to allow you to compare your performance to all 3 of those sort of comparative values. Up in the upper right-hand corner for this particular report, it's really going to tell you if you have where your risks lie, either in an organization or again at a facility level. You would be able to see if you're missing data. If you're missing data, you're going to be at risk of the CMP and the citation at FTAG 884. If you fail the QA, you may have some of the exact same risks. And again, the data is just extrapolated from the CMS file. It's not scrubbed in any particular fashion to try to determine this. It's basically what's being reported in the public domain. If this particular report will show by facility or the individual facility if you've had 3 or more cases reported within that time frame. Remember, that's one of the triggers for an on-site survey. The on-site survey, 3 to 5 days for that to occur, as well as a new initial confirmed case reported, 3 to 5 days for an on-site survey. But remember, even retrospectively looking backwards, this is something that surveyors could utilize to determine compliance with FTAG 885. They can actually zero in to when the facility had a week where they met a criteria and specifically ask for proof and evidence that you reported that information under FTAG 885. The first 2, the missing data, the failed quality assurance check, that's going to be a CMS imposition for FTAG 884. But the last 2 is data that the surveyors will use or the state agency will use when they come on site to determine if you're at risk for noncompliance of F885 and notifications of residents and families. So again, this is, we were trying to encompass a lot of the information that has come out through the QSO letters related to the enhanced enforcement remedies, where you are at risk in response to citations received based on survey history, based on the scope and severity. Pat and Hugh, thank you so much. You did such a wonderful job explaining all the information, ensuring that there's a deep knowledge of what's there. If you have any questions that haven't been answered or you would seek additional clarifications for anything, we do have our contact information here as well. Again, Pat and I both work for Team TSI. Hugh Heaton's the CEO of Regs in a Flash. Feel free to reach out to us. We'll try to answer any questions that you may have in response to the presentation today. And again, thank you all very much for attending the session. We're very happy that you chose to click on this particular learning session. And please enjoy the expo and convention. And thank you again for your time.